and I'm a registered nurse. CCRN in the float pool, and I'm a member of Denver Health Workers United. Happy to be here with you guys. I've been a nurse since 2012, and I've been in critical care since 2013. A lot of the information that I took were from these sources. Impact, ICU, and Vital Talk are connected. They're from a research grant that was provided to the University of California, San Francisco back in 2015, I believe. And then also the AACN has a lot of really great resources about end-of-life care. And then there's the End-of-Life Nursing Education Consortium, which is a 3-day long class. And I received the binder from that and got some education from that, as well as getpalliativecare.org. So this is the general definition for what palliative care actually is. Palliative care is specialized medical care for people living with serious illness. And this type of care is focused on providing relief from the symptoms and stress of illness with the goal of improving quality of life for the patient and family. This can be provided by specialty or primary care, and it is generally considered an added layer of support. And at Denver Health, we have a specialty care model where it's a consulted service. The service is available during daytime hours, Monday through Friday. So if you're on night shift or if it's over a weekend, the service is not available, which is really an opportunity for nurses to come in and kind of help meet that need in lieu of having that specialty service available. Palliative care is also based on the needs of the patient, not the prognosis. So the emphasis here is just that your patient doesn't need to be dying or at the end of life to really benefit from this. There's a lot of patients I'm sure you can all think of who have complex pain management needs or symptom management, like some really difficult nausea, or maybe the team's just not really getting along with the patient, or there's some kind of dynamic there that's not really working for the patient's benefit. And that's really what palliative care can help in terms of non-end-of-life palliative care. And it is available for any age and at any stage of serious illness. So this can be provided to pediatric and even neonatal patients as well can benefit from this. This is it's from when you have a qualitative study, there's a way that they can pick out words that people who submitted responses said the most often. So the largest words are the ones that were said the most frequently, and then the smallest ones are the ones that were less frequently. But all of these were primary words that were said by patients about the palliative care that they received while they were at the University of California, San Francisco. So some of the words that stuck out for me were together, improve, support, relief, stage, symptoms, and life, and extra. But those were pretty good. So here's the domains of palliative care in the ICU. So 3 big things: symptom management, family support, and communication. And for today's talk, we're going to be spending the bulk of our time talking about communication, and I'd encourage you guys all to participate once we get to those exercises. And then also we're going to be talking about psychosocial, spiritual, and emotional support, and a brief amount of symptom management, but that's all towards the end. Deaths in the ICU, really tough to find good quality information about ICU deaths for over the last year, because obviously numbers have changed so much since COVID-19, but from a study that was done in the Anesthesia Journal, they said over 80% of ICU deaths were attributed to one organ failing, and expected deaths are more common than unexpected deaths, which is, we would think of like withdrawal of care. And then I can't remember specifically where I got these top numbers from. But prior to COVID-19, there were approximately 500,000 deaths in ICUs annually in the United States, which would provide an 8 to 19% mortality rate. So there's more deaths in the ICU than any other unit in the hospital. Here's the continuum of care. And the disease progression goes up like this, and the patient dying would be here. And so the point of this is to really emphasize the difference between palliative care, hospice care, and bereavement. So palliative care is provided during all of those stages. But this hospice care is its own discipline. So the differences here would be palliative care is for the whole time that the patient has a serious illness versus hospice care, which is in the last 6 months. And the focus of palliative care is quality of life, symptom management, and living well with illness versus hospice care, which is preventing suffering during the last days. And then communication for palliative care is primarily focused on clarifying goals of care and defining what the meaning of a good life is for that patient, whereas hospice care is finding preferences about end-of-life care and what it means to die well. If you have a patient and you're like, things aren't necessarily going the way that we want, but you're unsure whether or not a palliative care consult formally is a good idea, then this is a tool that's been developed in the University of UCSF to help you really decide whether or not, as a bedside nurse, whether this is something that we should be advocating for. And I don't know about you, but a lot of my patients in the ICU would qualify if this is our assessment that we're going to be doing every shift. So nurses in the ICU, this is in general. This is, besides charting and cleaning and administering medications, this is some primary roles that we do before we even engage with palliative care. So we become a calm and human presence in the midst of chaos and suffering. And we bear witness to a lot of that suffering. And I think that that can be a real source of moral distress and burnout and a lot of issues with nurses, and can be kind of threatening to our profession. But hopefully, as we'll talk about this, you'll find some ways to maybe manage some of that a little bit better. We do get a lot of intimacy from physical care, of taking care of our patients. Things like, every 4 hours we do oral care for our vented patients. And if you notice that every time you put a yank hour in their mouth bleeds and they wince, then, they're pretty uncomfortable. If you turn them and, their whole body tenses up, you're more aware than maybe a physician or even a family member that's in for a short amount of time doing a physical assessment that's a little less hands-on. And one of the goals that we do as nurses too is to help patients and families regain a sense of control. When patients are in the hospital, from their perspective, things are just being done to them. People are walking in, giving them big information, and then they're just treating them. And so we really want patients to feel like this is their life, and that they have the ability to be empowered to make their own decisions. So I won't read all of this to you, but the American Nurses Association and the American Association of Critical Care Nurses both really want to stress that nurses are supposed to serve as a moral agent, working on behalf of the family, and that we're working towards the patient's values, which may be distinct from our own values. And I put a quote in there about moral distress, which is what happens when we feel that there's an ethically correct action, but we're constrained from doing it. And so this is really, really common in the ICU when we say, gosh, the patient is suffering and this is horrible, and the family just won't let go. And I have distinctly recalled points in my career where I felt very resentful of the hope that my family members had the patient would get better, because it just seemed so impossible that they would get better. So kind of a transition that we can make to prevent this moral distress from occurring is to engage with a more palliative care perspective, which is that we don't necessarily want our values to be expressed, but we really want the patient's values. We really want to understand the patient through the family members and help that transpire, even if that means that the patient's going to die on a ventilator with low sedation. We just want to make sure that they understand their healthcare options really well and that they're able to make an informed, empowered choice. So understanding grief is going to be really important as we help our family members along this process. And the Kubler-Ross theory, it's been around since 1969. Obviously, a lot has changed since then. The way people die has changed a lot since then. We used to think about this in terms of stages, and now we think of it more as cycles, that denial, anger, bargaining, depression, and acceptance. And then we also know now that people will start the grief process prior to the patient actually passing away. Really common feelings and emotions: sadness, anger, guilt, anxiety, and really common behaviors, sleep disturbances, social withdrawal. All of these things are things that we can help encourage family members to mediate, basically. You know, are they taking breaks? Are they contacting their social network? Are they sleeping well? Are they remembering to eat? And kind of generally, how are they doing? You know, we really want to encourage them through this grief process. And then class and cultural considerations for end-of-life decision-making. This can really help, when you start thinking this way, it can help illuminate why people are making the choices and hanging on to the hopes that they're hanging on to. So a good class one would be, I had a family member who we knew for sure that this patient was not going to survive, and the family just wasn't coming around. And then as I talked to the family, they said, well, he is the main breadwinner and my mom is disabled. So not only is this family having to deal with losing a family member, but also economically, without this primary breadwinner, they're potentially going to be living in worse poverty than they were prior. And then cultural considerations for end-of-life decision-making. I think of the men wanting to make decisions, and some cultures that we serve at Denver Health can be it's like kind of a masculine focused culture. And sometimes if the man gets sick and the woman is the power of attorney, sometimes that woman doesn't feel empowered to make a decision because she's not been in that role culturally for most of her life. And then the other thing that I said before, I really want to encourage you guys to seek to understand who the patient is, what their values were through the visitors who were at the patient's bedside. It may not be family, it may be friends, but sometimes, as we know, the power of attorney who's making these medical decisions isn't somebody that's necessarily a real decision-making kind of person. And, you know, we want to be learning about the patient through everybody that's there. So these are some trajectories of dying. This can also help you understand where people are coming from. I think of this first one in the top left as patients that we're never really going to see as in an inpatient setting. We might see them in the emergency department. But in terms of palliative care, there's not really a whole lot that we're going to be doing other than bereavement care. This terminal illness on the right, I would think of, you know, like a cardiac arrest patient who's going to be there for a very short amount of time, maybe 3-4 days before they pass away. And then this bottom left just looks like COVID, where they're getting better and then they're worse, and then they kind of have an overall downward trajectory. But those families tend to be exhausted. There tends to be trust issues between families and the healthcare providers, and those can be very, very challenging. And then the frailty on the right are what we think of older folks who come in with multiple chronic issues. Their quality of life is already probably pretty limited, often coming in from facilities. And so the families are a little bit better prepped for whatever it is that brought them into the ICU. And then this is a quote from the American Association of Critical Care Nurses. And I thought this was so interesting because at the bottom it says, the nurses were there to interpret and soften the blow, to break it down and explain it, and register the looks on some of my family members' faces. And I think this is a tremendous ask for nurses to be so emotionally engaged with families, and then to be able to break down complex medical issues in layman's terms. But this is something that our regulatory body really wants us to engage with. So I think that's also a really cool thing to get to start doing. And this is also something that I didn't mention prior, but hospice care is something that the insurance companies can be billed for. Medicare, Medicaid cover hospice care, but palliative care is provided by the hospital and also through philanthropy. So there's not a lot of money there, and this really is like kind of the nurse's realm at this point. So the 4 C's and key roles for nurses in communication. So convening, checking, caring, and continuing. So convening to make sure that disciplinary rounds are happening, that families are being involved in rounds, that they're actively being updated by physicians on a regular and appropriate basis. If they came around in the morning, but then all of a sudden the patient's on 4 pressors in the evening, then we need to make sure that the family is being updated on that. And then checking to make sure that the family had a meaningful interaction from that update, and checking to make sure that they know what's going on, and that we're also engaging with their emotions and responding to their feelings in a meaningful way so that they can then absorb the information that's being given to them by the physicians. And then continuing following up with the discussions to clarify and reinforce information and to provide support. So what's your comfort zone? So I think the one to start with that everybody starts with is silence. And that's normally where you were leaving the room as quickly as you could when things were awkward. You started staying in the room, quietly making space and making yourself available while not really engaging with what was going on in this emotionally charged environment. And then these bottom 3s is where you're kind of engaging more with the family. And this left side is what they teach us to do in school, this telling, talking, and giving information we're all so good at. And I think part of that is because of the personalities that kind of end up in the healthcare field are people that really enjoy data and like talking about information. And so I think it's partially empathetic, I think it's partially training, but it's not always what our patients need at that time, what their family members need at that time. A lot of times they need this other end of the spectrum, which is asking, listening, and responding to their emotion. And I've got a little video here. This is from Vital Talk. And it's kind of geared more towards physicians learning to have better communication skills, but I think this particular video is actually really, really helpful.
Communication specialists say that there are 2 channels of communication that go on anytime you're talking to someone. One is the emotional channel, and the other is the cognitive channel. And what I think is most important is that the emotional channel is both quicker, and so it sort of wins over whenever there's a fight between emotions and cognition. It's faster and it's more powerful, which means that if you're feeling emotional, the sort of cognitive part of your brain is often gone silent. And what that tells me is that if I'm sort of talking to someone, I need to be really sensitive about what their emotional state is. And if they begin to express strong emotions, I need to recognize that and attend to the emotions before I try to give them cognitive information.
So emotions before cognition, and family members and patients will give you emotional cues. And it's really important when we're having these delicate conversations and when we're present during this heightened emotional and stressful time for them, that we not ignore those. We make space for those. We validate those to help them to move to a space where they're able to make good quality decisions at this end of life in this important time. So here's these 3 conversations that the AACN really emphasized, and they're in a circle. And I think the circle really starts here at the top, and it's the nurse-family conversation, then it goes to the nurse-physician, and then the family meeting. And so this nurse-family conversation is really just understanding where they're coming from. What's their understanding of the prognosis? How are they doing? What are their needs? Do they need a hotel? Do they have good transportation? Are they hungry? Is it really cold in the room? What can we do to get you guys to be present with what's happening? What kind of distractions can we eliminate for you? Are there doctors that you really wanted to talk to that weren't here? And then, so really they'll ask you, and I think in these first conversations, they tend to ask you a lot of information questions. And a lot of the reading that I did encouraged you to kind of not bite on that and move more towards the emotional side. And we'll talk more about that. And then you're going to go to the nurse physician conversation, where we're trying to get a good feel for the prognosis and goals. And a lot of times we know kind of what it is, but we want to hear from the physicians directly what specifically it is, so that we can help present gaps to them in what they're saying versus what the family is saying. And then you want to kind of have everybody come together in a family meeting where we talk about these really important topics and make sure that the family understands. And a lot of the family meeting piece is going to take a lot of preparation for the family. And so I always encourage families to have a notebook, and they write their questions down as they come up, starting from day one. So when that family meeting occurs, they either have those questions answered along the way, or they're able to ask specific questions. And if they're people that want numbers and percentages, to start to think about what those numbers and percentages are. You know, are they ever going to be able to walk again? Are they going to feed themselves? Will they recognize me? Are they ever going to be able to work? Are they going to be able to drive? Because families need to be able to start thinking logistically for the future when doctors start presenting scenarios like trach, PEG, long-term care, and then, you know, they just need to be able to prep for that. So we're not really taught how to do this, but this is what we're talking about today, is this communication toolbox, how to have those conversations more effectively. And there are these specific skills. So when we want to elicit another's perspective, so in those first conversations between you and the families, and then between you and the physicians, we want to be asking a lot of open-ended questions, and I'll provide you with some examples. But then also this question of tell me more. Sometimes families and patients will come out with very charged statements, and you really want to dig into those. And sometimes just an open-ended tell me more, we're not directing this in any way, we just want to hear from you, can be helpful. And then for providing empathy, there's reflection statements, and then there's a framework for a variety of different responses. And then for giving information, so this is what we kind of want to do less often, would be hope worry statements and ask tell ask questions. And I think it can be kind of tough in these scenarios, especially when the patient's really sick, to really engage with this. And so I would say to keep it goal oriented. And if your patient is super unwell, and you're just replacing drips all the time, and it's crazy, and there's a million people in and out, that sometimes relying back on what you learned early on and just being silent and creating space for a couple of moments can be really helpful. You want to remember that this is a skill, not a talent, and it takes practice. And also that these skills are going to work across all the conversations. So you can be using these same skills that you're using at the bedside, also with physicians, and also with each other if you're noticing that you have a coworker who's really struggling with the death of a patient. Okay, so this is the part where if you guys would like to participate, this way I'm not reading this whole slide to you, feel free to jump in. But here are some open-ended questions to elicit another person's perspective. So does somebody want to read off one of those that sticks out to them?
I'll read something for you, Kate.
Thanks.
I'm going to skip down to about the middle and say, if your loved one could see themselves right now, what do you think they would say? What do you think they would think about their medical treatment?
Yeah, I really like that one too. And I think that's one that we're maybe not super comfortable with at the start, because it can be like a can of worms. So for some of these ones that that are really charged, feel free to take a seat. Studies have shown that the time that you actually spend sitting down face to face with a patient is less than how they remember it. So it means so much more to them down the line than it did for you taking 5 minutes out. So that was a really good one. I also really liked that the doctors talk to you about what your loved one's recovery might look like, about their prognosis, or what information would be helpful for you. And then one that I have used a lot in my time during night shift, when we get patients in that are just super sick and the plan just seems pretty crazy sometimes. You know, we've got patients who have like stage 4 cancer, and all of a sudden we're putting them on CRRT when they had a most form that said they didn't want any of this. I've used this one where, have you or anybody else had discussion with the patients about what they would want or medically would want if they ended up on life support? Have you ever had a parent or grandparent that was in a similar condition? So open-ended questions to elicit response. And then reflection statements, where you're basically just feeding back to them what they've said and kind of checking it with you. So it sounds like this is really stressful for you, or it seems like you are really worried that you and the docs aren't on the same page. It seems like there's a lot of love present in this situation. I really like that one a lot too. And then this acronym NURSE, to help express empathy effectively, where we name what the family member is expressing. We convey understanding. I don't especially like saying anything like "I understand," because I don't understand. Every situation is different, but you can say things like "I can't," "I could never understand," or "I can only imagine." You want to express respect, support, and also to explore. So if the family says, it's been a really hard week, you could say, "You sound frustrated," or "I can only imagine how hard this is for you," or "I really respect how much you've been here at your wife's bedside." And then also remind them that we're there to help them, and then to ask them, what's the hardest part about this? And then here's one to help with that we could use with our physician colleagues. Sometimes, we're really frustrated, and then we talk to them and we also get the sense that they're very frustrated with the case as well. And we can say something like, "I know this has been really challenging for you. These discussions are difficult," and that's type of thing. And then ask, tell, ask. This is a way to get permission to present information, and that can be really important in situations that are overwhelming for families. We want to make sure that they're ready for information and not overwhelm them. And then we want to present information as clearly and as simply as possible, and then to make sure that they kind of got the message. So this is another one that we get a lot is, "Well, what do you think? You see this all the time. The doctors are saying this. What do you think?" And for us, we could say, "That's an important question, and I'm happy to discuss this with you, but what is your sense of things?" And then the family member could provide something that sounds very hopeful, like "She sounds very peaceful." Maybe that's a good thing. And then you could say something like, "I also see that she's being sleepy." So then you're aligning yourself with the finding that the family has expressed, and that "I'm worried because, we've had to increase her sedation to help her tolerate the ventilator, which is now at a much higher level of support. So she's more sedated today than she was yesterday." And then your ask would be, "I think it's important for us to discuss your daughter's status with the doctors. Can we arrange a meeting?" So again, an emphasis on getting a family meeting, hearing that the family is coming from a very, very unrealistic point of where the patient is, and wanting to realign everybody together. And then this would be one for in a family meeting. So the doctor could start off with saying, "She's got renal failure. We haven't been able to stabilize her electrolytes, and at this point we're looking at long-term renal replacement therapy." And the husband might say something like, "Okay, that sounds good." And then that's your job as a nurse to jump in and make sure they understood what the doctors were saying. So if I may, just want to make sure that we're being clear. Could you tell me that what you've understood of the conversation so far? And the husband might just say that it's very confusing. And then you could say, "If I understand correctly, Dr. Taylor is worried that your wife will need dialysis, perhaps permanently. Does that make sense?" yes, I get it. I'm just not sure she'd want that. So the nurse then is not only participating in the family meeting, but they're also simplifying the language, and they're double checking to make sure that they're hearing what the physicians are saying while they're in the room. And it also gives the docs an opportunity to jump in there too. And then hope worry statements. I think these are super, super helpful when there's a trust issue between the family and healthcare providers. And that's where we're validating what they're saying and then also bringing up concerns with what the reality of the patient's condition is. So we're hoping that she gets stronger too, but we're also worried that her kidneys are showing signs of worsening. Or I was hoping to hear your perspective on prognosis and goals of care. Do you have a few minutes to talk about this evening? Or we're hoping also that she'll be able to wake up and see her grandbaby. But if I understand the doctor correctly, we're worried that her neurological exam isn't improving. So that's kind of the communication bit. So terminal processes, this is as your patient's actively dying. A lot of us have seen what that looks like, but just to define in your physical assessment, knowing that your patient who's passing will have difficulty managing secretions and swallowing. They often will be agitated and delirious and have changes in respirations. The loss of ability to close eyes can be really concerning to family members, so providing eye drops and that kind of thing. Loss of sphincter control, pallor, grayness, pain, and dyspnea are all very common. And I think it would be incomplete to have a talk like this without talking about ventilator withdrawal. So when we withdraw the ventilator, it's super important that we educate families prior to taking them off of life support to tell them about those terminal processes. And I think one of the best ways to prep them is to first thinking about what was it that led them to be intubated in the first place? Was this airway protection? Do they have a ton of secretions, or are they somebody that's going to need to, are they somebody that's going to look like they're working really hard to breathe? All these things are going to be really emotional for families, and the more we can prep them beforehand, the better. And it is appropriate to pre-medicate patients prior to extubation, knowing that they're going to be immediately air hungry and often full of secretions. However, we want to make sure that they're able to overbreathe the ventilator prior to withdrawing, because obviously if they're riding the ventilator 100% and then we pull their tube, then we may have done a little bit more than we intended to. So make sure you've got your extubate now order, patients out of restraints, and pre-medicate them, make sure they look pretty comfortable. And then, we often give benzos and opioids and some anticholinergics for secretions, but I really want to emphasize here that the family's evaluation of how things are going is super important and can often guide how you medicate the patient. If you're educating them and they just seem like they're struggling, I think it is appropriate. A lot of the pain assessment scales at end of life do include the family's perception of how the patient's doing. And we want to invite them into this process. This is their loved one and they have the right to participate in cares. So not only do we want to let them know that it's okay to touch the patient's hand and face, but also to participate in cares, including, turning, cleaning them up, getting them dressed into clothes that they would have preferred to be in, making sure that they have really important belongings on them, sometimes a necklace, sometimes a religious belonging. I worked for a while in Seattle with tribal people who had these little woven boats that were really important that they be at the bedside. Here in Colorado, I've seen a lot of Catholic religious belongings and also crystals and that kind of thing. And then music and song, making sure that they know that it's okay that they put music on. If they want it on loud, we'll let them know if it's too loud, but to go do their thing. Having photos up around the room, talking about the patient's legacy. I think it's really funny that You know, we have this habit of being really quiet in rooms and when patients are passing away, and certainly in a lot of circumstances that's appropriate, but I can distinctly remember a few patients who passed away where the family members were just telling their favorite stories of the loved one, and they were laughing to the point of tears. They just thought it was a really great get together. We want to make space for their emotion in the ways that we talked about earlier, but also in your own way of letting people be people as their loved ones are leaving. And then we want to be open and honest, not only about what's to come, but once the patient has died. You know, what I tend to do is leave the monitor on, and then when it's dinging and stuff, I kind of go in there and I just tell them, I'm so sorry, but that dinging is just that the loved one has passed away. And I think that can kind of helps. So burnout prevention in ICU, we get burned out a lot because we see so much death. And some things we can do to help is to remember that this is a skill and not a talent. It doesn't have to be perfect. And that sometimes no matter what we do, we can be the best possible care providers and the patient's still going to have a really horrible death that traumatizes the family, or people are still going to have complicated grief that's a result of their complicated relationships with their loved ones or their complicated relationship with the world in general. And that's okay, that's not a reflection on us, that's just a reflection on the challenging work that we do. And I also want to emphasize supporting coworkers. There are some people that end up in challenging environments that don't intend to stay very long. And so these couple of times that they'll withdraw care or be a part of a death can be really, really challenging. I remember there was a nurse that was hoping to go to anesthesia school, so she was putting her time in, and she was like, I don't want to be in the room alone when I have to turn the drips off. And then when we got in the room, she was like, I can't do it. And she felt that that was her killing the patient. And you know, we want to make space for them too in their experience and help meet them where they are. And if you're somebody that has a hard time with this, I'm not super great at this, but I know of people who really are. And so I tend to try to debrief with them through mentorship. And then developing rituals for really challenging deaths. I know in pediatrics, there's some really, really tough deaths that y'all have seen and participate in, and developing rituals can be really helpful, like lighting candles or, you know, having your own routine that you would go through on your way home from work. Organizing memorials. I think in peds especially, a lot of their debriefs are almost like memorials. Yeah, so those are some of my tips on burnout prevention and a little bit about palliative care. I want to open it up to questions. What do y'all think?
So thank you so much, Gabe, for doing this stuff. All this is brand new to me. So really, my big question is that when is the earliest time, or maybe like the least acute patient really that could benefit from a palliative care approach combined with whatever else they're getting? Is there a too early?
No, I don't think there's a too early. I think anybody that has complex symptom management needs with a serious illness could have a palliative care consult. And I think here we'll go back up to this slide too. So any family that's really struggling to cope, even if it's for an illness that we know that they're going to recover from, but they're really struggling with their time being in the hospital for whatever reason, could benefit from palliative care. Or if there's any kind of goals of care discussions taking place, certainly that would be a great time. But I don't think there's any time that it's too early. I know at some facilities they have a palliative care consult right when they're admitted to the ICU, so every patient gets one. Well, I think if that's it, I just want to thank you guys for being here.
Well, okay, can I say something?
Yes, of course. Please.
Yeah. Yeah, I'm an organizer on this campaign, and the head organizer thought that it would be good for us organizers to maybe just get on and see what you could, you know, what you guys are doing. And this just gives me a better appreciation for the job that nurses do. And it gives us a better understanding when we are talking to some of your coworkers about joining union. And it's, you know, we do need to, as union organizers, understand what kind of job you guys do. And it certainly gives me a better appreciation of what you do and understanding about what you do. So that's my comment. That's why we're on it, you know, me and Diane's an organizer too. And just to understand what kind of work you actually do, because we don't want, in CWA, we don't want to be just going, you know, getting people to sign up. We need to understand what kind of job you do. And I just want to thank you guys, all you guys that are nurses, because this is really giving me a better understanding of what you actually do. That's my comment.
And
Well,
Kate, I just want to say, this is Diane. I just want to say thank you for this presentation. I've been through the palliative care with someone before here in Cleveland, and I've you know, seen how it works, but the scope of what you've presented gives me a much deeper insight as to, you know, how much you guys are involved in this. And it's quite a lot. It really is quite a lot. You guys have to be more than a nurse. You know, you guys are more than a nurse. You're more than family. You're more than a friend. You're more than a counselor. You're more than a religious person. You know, you're more than, you know, you're just more than your worth. You're more than you're paid. And I just appreciate you guys for what you do. And, you know, there's a special place for you guys, and you're special people. You really are.
Well, you're making me blush, Diane.
No, you're worth it. You're worth it. You really
Thank
are.
you so much, ladies. I really appreciate you being here, and I appreciate the work that y'all have been doing in our campaign, and thanks for helping us out, you know.
We appreciate you guys too.
Hey, I just wanted to say too, thank you so much. I feel like you conveyed all of that information really beautifully. And I definitely see myself being in critical care at some point. So I got a lot out of this. And I think especially when you're in school and you're thinking about critical care, you're thinking more about the like the critical thinking aspects and the academic piece and, you know, all of that. And so I think you really touched on like a really big part that people don't consider as often. And in our culture, generally, I think people don't, we kind of like look in the other direction of death. And so I think it really takes a special person to be able to just be there with it and hold space for the family and guide those people through that and guide the patient. So yeah, I just thought you did a really excellent job.
Oh, thank you, Cassie. Appreciate that. And you should come to critical care. It's a pretty great place to be. All right, you guys. I hope y'all have a good night. Thank you